Thank you very much, sir. This is a study which was conducted in SKIMS, Srinagar, and titled Clinico-epidemiological Study of NHL in Kashmir. The aims of the study was to define a clinical and laboratory profile of NHL patients at SKIMS, to determine the distribution of various types of NHL in SKIMS, to do their staging work on prognostic factors as per international protocol, and develop treatment modalities and survival patterns of the population. Next. The material and methods consisted of that the study was done at Shiekh Institute of Medical Sciences, and the diagnosis of the disease was done by histopathology. Subtyping of NHL was done on the basis of immunohistochemistry, and all patients diagnosed were analyzed for clinical presentation by history and examination. Complete standard lab workup consisting of hemogram, biochemistry, as shown, was done, and they were classified as per the WHO classification. Staging was done as per Ann Arbor staging, and prognostication was done by International Prognostic Score, IPI, and FLIPI in case of follicular lymphomas and mantle cell lymphomas, IPI. The type of treatment given was chemotherapy, radiation, and targeted treatment as and when necessary. Reassessment at the end of treatment was completely done on the basis of clinical assessment, lab parameters, imaging, response rates, and overall survival and relapse rates. The total number of patients from 2009 to 2014 were 410, and males were more than females, comprising of a ratio of 2.3:1, with follicular lymphomas more common in males and ALCL in females. The socioeconomic setup revealed that most of our patients were in lower middle class and middle class group of subsets of population. The mean age at presentation was 49.3 plus minus 18.963 in males and 49.06, 18.342 in females. Most of our patients belong to age group of 60 to 70 years of age. But in children, which consisted of age less than 90, the total proportion was 8.5% of total population. Occupation, farming as an occupation was seen in 34.1% of patients, especially males, and school teachers comprised of 1.5% of total population. Smoking status in relation to gender were noticed in 30.7% of all patients, with significant numbers in males. Smoking was tried to correlate with the immunohistochemistry subtype, and there was an insignificant association with mantle cell, follicular lymphomas, and SLL. We tried to show the presentation on most of the patients, and lymph node enlargement was the commonest presenting complaint in 44.1% of patients, followed by gut symptoms in 11.1% of patients. Most common site of lymphadenopathy was in the neck, and all subtypes except Burkitt's lymphoma, the gut symptoms predominated. B symptoms were seen in lesser number of patients in our setting, comprising of 21.7, and in all, we saw in nodal presentation, we had 254 patients having these symptoms. Overall, extranodal disease was found in 38% of our patients, with pure extranodal disease in 21.7%. The extranodal disease sites were gut, 26%, ENT 26%, and in the ENT, tonsil was the commonest presentation, comprising of 50% of the patients. Immunohistochemistry at the diagnosis was available in 61% of our patients, and B-cell lymphomas comprised of most of our patients, comprising of 90.09% of the patients, and T-cell lymphomas 9.91%. DLBCL was the commonest type of the lymphomas, and it accounted for 63.2%, followed by follicular lymphomas 7.2 and mantle cell lymphoma 5.2. Among the T cell lymphomas, T lymphoblastic lymphoma was the commonest, comprising of 4.8%, followed by ALCL and PTCL. If you see this most of the comparative age of the study subjects in relation to immunohistochemistry at diagnosis reveals that most of our patients were in the 5th and 6th decade, but in children, as you see the T cell lymphoma, the age was lesser, and we saw most of our patients in less than 19 years of age. And our staging revealed that most of our patients were in stage 1 and stage 3. This is in contrast to other Indian studies where most of their patients were in stage 3 and 4. So we had most of our patients in stage 1 and 3. This is the risk stratification in mantle cell lymphomas, and follicular lymphomas. We found the low risk and intermediate risk and high risk, all the categories, but most of the patients belong to intermediate risk. Bone marrow involvement in different types of NHLs is shown in the picture, and then we found that not many patients had bone marrow involvement as far as adults are concerned, but in children, the quantum of bone marrow was more than that of the adults. Once we treated these patients, the response to our patients was very good, and the response rates ranged from 83 to 91%, and partial responses were seen in 5 to 13% of patients. Progression of disease was seen in only 3% of our patients. Kaplan-Meier survival analysis of the subjects with those who completed chemotherapy is shown in the green, while those who did not, as you can see, they had an inferior outcome. And Kaplan-Meier survival analysis of the subjects with NHL with respect to immunohistochemistry was also shown on this graph, and showing that most of our patients did well with the chemotherapy. Relapse rates were found in 15% of patients and were highest in follicular lymphomas, followed by mantle cell, marginal zone lymphoma, T cell lymphoblastic, and DLBCL in the descending order, respectively. Relapses were seen in 17.6% of our children, which was slightly higher than adults. Thank you very much.